So thank you all for coming. Thank you for joining us before this long weekend. Today we have an external invited speaker, Dr. Tim Hoenig. And Dr. Hoenig is a clinician scientist. He's at the University Medical Center Hamburg-Eppendorf. He's in the Department of Trauma and Orthopedic Surgery there. And what I think is pretty cool, he's also the team physician for all of German athletics. So we have him here to give us a talk on the clinical aspects of bone stress injuries. So his main interests are in bone and really all clinical aspects of overuse and sports injuries. And if you're in this area of bone stress injuries, I'm sure you've read his work, and he's recently written the foremost review on bone stress injuries, which was just published in Nature Review. So I encourage you to take a look at that if you can. So it gives me great pleasure to introduce Dr. Tim Hoenig today to speak to us. He's here because of funding made available through the University of Hamburg and the University of Calgary. Apparently there's some money for exchanges, so he's been here for 2 weeks, enjoying the mountains and speaking with some of us this week. But there may be, from what Tim tells me, more money coming for this exchange, where there's opportunities for potentially students to do long-term exchanges back and forth. So hoping for that. So without further ado, thank you, Dr. Hoenig. The floor is yours.
All right. Thank you, Brent. Really much appreciate the invitation to give a talk on this topic. Clinical aspects of bone stress injuries, how much loading can a bone withstand for how long? And I would like to start with a short introduction. You all know that a bone can fracture due to a single trauma, as shown on the left. So this is a 41-year-old cyclist who fell from a bike and got a proximal femur fracture. However, a bone can also break in the absence of a macro trauma due to repetitive micro trauma, as shown on the right. So this is a 39-year-old long-distance runner who developed hip pain for a time period of 1 month. He did continue training by using pain medication, no prior medical history, and he also got a femoral neck fracture. So a stress fracture may be seen as nothing else than material fatigue of the bone, as any other material, any other tissue fails if there is enough stress and strain, and the stress fracture therefore may just be seen as the end of a spectrum of overuse injuries to bone that range from mild signs of bony overuse to a complete displaced fracture. And this is clinically shown here, 3 images of 3 marathon runners with pain over the midfoot. On the very left, a patient with a forced metatarsal pain, and you see a slight, tiny bone marrow edema. And in the middle, again, marathon runner, pain over the 3rd metatarsal. You see a bone marrow edema all over the 3rd metatarsal, but a hyperintense fracture line in the mid-metatarsal shaft. So a classic 3rd metatarsal stress fracture. And on the right, you even see a slightly displaced stress fracture in a marathon runner. So when I say bone stress injuries comprise a spectrum of overuse injuries to bone, ranging from mild signs of bony overuse to a complete displaced bone fracture, there are other clinicians, researchers that say, no, it's not a spectrum. It's more than a spectrum. It's a continuum, meaning these injuries start slowly, and with continued loading, it gets worse and worse, and only the final result then may be a complete bone fracture. And this is why classifications have been introduced to the literature. And don't worry, I'm not going on all of the more than 20 classification systems on bone stress injury, but I would like to show you one of the most popular, and that's the Frederickson classification, named after Michael Frederickson from Stanford University, who already in 1995 showed that there's something we consider to be a grade 1 injury, which is basically just a periostitis or periosteal reaction. Then there's something we consider to be a grade 2 or grade 3 bone stress injury, where you can see a bone marrow edema. And only in the grade 4 or in this modified classification, the grade 4B injury, you see a cortical fracture line or fracture-like defect. And for everybody who's dealing with athletes, it's quite important to know at what stage or what severity the injury is, because we do think from a systematic literature review that the higher the injury grade is, the longer it takes to return to sport. So I now already mentioned a few terms: bone stress injury, bone overuse injury. When you talk to colleagues, you hear a variety of terms, including insufficiency fracture, bone edema, bone marrow edema syndrome, hairline crack. And I don't want to go too much into detail on terminology, but we do need to ask the question, are we speaking the same language when talking about these injuries? And the terminology that has been previously been used, and I still kind of like it, although it has some major problems, is that every bone fracture that was caused by cumulative bone loading has been termed a stress fracture. And then there were two types of stress fractures, including the fatigue fractures and the insufficiency fractures. And fatigue fractures were defined as abnormal high excessive stress applied to normal bone, and insufficiency fractures were defined as normal stress to abnormal bone. But there has been, as I mentioned, some issues with this terminology. One is that we do think that bone overuse injury do not necessarily have to be a fracture. We do know that there are athletes with high excessive stress applied to bone who also have underlying skeletal health issues. And also clinically, the term stress and fatigue fractures were used interchangeably. So today you most commonly read in the literature the term of a bone stress injury, which is kind of a broad term and may be defined as abnormal high stress applied to generally normal bone. And we do think that there are different stages or grades of injury, including low and high grade injuries, and the differentiation between these two may be a macroscopic fracture line, and the same, by the way, may apply to bone insufficiency injuries as well. So this is how we think these injuries occur. With every kind of repetitive loading, micro damage may occur, which is generally thought to be something good, as by Wolff's law, this makes the bone stronger rather than weaker. However, with the accumulation of micro damage, an imbalance in micro damage formation and repair or removal may occur, which may lead to the failure of toughening mechanism and the occurrence of a bone fracture. Bone stress injuries are typically seen in sports involving high and repetitive loading. We very often see them in runners and track and field athletes. They are also common in dancers, gymnasts, but also a variety of other sports, including team sports, basketball, soccer. What's quite important to know is that the type of activity really determines the site of injury. So we do know that in dancers, a typical injury site for bone stress injury is the second metatarsal base. And we do know that with throwing athletes, we may see bone stress injuries at the vertebral arc, term for many years as spondylolysis, but it really turns out that in the active population, the underlying etiology is overuse to the pars interarticularis or the vertebral arc. And I'll give you a few seconds to think about at what bone site a rowing athlete may be prone to develop a bone stress injury. So we do know that in rowers we see rib stress fractures due to rib cage loading during the rowing stroke. And in climbing athletes, we may even see bone stress injuries at non-weight bearing bone sites, including the hand and the carpal bones. Basically, bone stress injury can virtually occur at any bone that is loaded. This is a rare but interesting case report from the literature of a 31-year-old male who played virtual reality games up to 4 hours of an almost daily basis with a lot of repetitive head movements. And this resulted in a stress fracture of the spinous process of the 7th cervical vertebra. Another case report from the literature is this 44-year-old male who had persistent cuffing, which resulted in the stress fracture of the right 7th rib. So there are a variety of risk factors that may cause or contribute to the development of a bone stress injury, and for easy understanding, they may be grouped by risk factors increasing bone loading and by risk factors that may impair skeletal health. So we need to talk a little bit on training load. We need to talk on biomechanics. We may discuss the issue of muscle and strength, shoes, insole, running surface, and on the other side, when it comes to risk factors that may impair skeletal health, we need to discuss relative energy deficiency syndrome in sports, calcium, vitamin D, bone mineral density, bone microarchitecture, sleep disorders, early sports specialization. And I'll go a little bit more into detail on some of the risk factors in a bit. And the good thing about most of these risk factors actually is that these are considered to be modifiable risk factors, which means that you can use the long treatment time that is typically associated with these injuries and the long time to return to sport to identify and to address underlying risk factors. So as I said, I'll talk a little bit more on some of these risk factors. And when it comes to bone stress injuries in athletes who are by definition caused in the presence of high repetitive loading, we need to talk a little bit on training load. And when you go on the internet or read running magazines or talk to coaches, you may see something that it says running more than 20 miles per week may be associated with bone stress injury. And there's actually not really evidence to that, but in fact, the total amount of training volume or training intensity seems to be less important, but rather a sudden change in training. So you really need to look at recent transitions, including transitions in increase in training volume, training intensity, a change of training type, including cross-country running to road running, recent returns from breaks due to injuries, illnesses, or off-season, novice runners, of course, and young athletes moving into a new age group. Another risk factor that has fortunately got more attention is relative energy deficiency in sports, and I'm quite sure you have heard of this, but just to make sure we're on the same level. So RED-S is defined as a condition of energy deficiency in athletes by low dietary intake and high energy expenditure, causing adverse effects on almost all bodily system. And it does matter because it impairs growth and development. It has an impact on health and well-being. And for me as a clinician, this sometimes needs to be the argument towards some athletes and coaches who are more interested in performance rather than a health issue. It also has an adverse effect on performance. So I'm not going to talk about all the adverse effects of RED-S, but as we're talking on bone stress injuries, we need to talk a little bit on the implications for bone health. As we do know that a low energy availability, a state of low energy availability, affects hormone including insulin, IGF-1, T3, estrogen, and may lead to low bone mineral density and also impaired bone knee microarchitecture. And I really love these images. This is from a study from Ackerman et al. From Boston, who did this imaging of HRPQ-CT of the tibia in athletes, where we might think that runners in general have, due to the impact loading, a higher cross-sectional bone area at the tibia, but this group showed in this paper that athletes with amenorrhea actually have a reduced trabecular and cortical thickness compared to controls. I want to talk a little bit more on bone mineral density and bone microarchitecture, as there has been recently a discussion going on how this affects trabecular and cortical bone size. So when it comes to bone, we do differentiate between two types, including the cortical bone with a thick outer layer and the trabecular bone with a thin cortex, which predominantly consists of trabecula. And this can be the situation within a bone. So when you take a look at the femur, the femoral shaft may be considered a predominantly cortical bone site, and the femoral neck may be considered a predominantly trabecular bone site. But we do know that bone stress injuries are seen in both trabecular and cortical bone sites. So again, when it comes to the femur, we do see bone stress injury at both the shaft and the femoral neck. And the hypothesis in the literature has been that trabecular-rich bone is more metabolically active and sensitive to changes in hormones caused by low energy availability. And in fact, 1040 et al., who's one of the greatest clinicians I know when it comes to running-related injuries, he and his group actually showed that triad risk factors are more common in athletes sustaining bone stress injuries in trabecular-rich than cortical-rich location. Although we, in our own investigation, showed that impaired bone microarchitecture is present in athletes, although we did not see a difference between injury size, and I really recommend further investigation. I think this is a quite interesting topic to study, and I'm pretty sure there will be some studies coming out in the next years. So I cannot come to Calgary without talking about running shoes and insoles. As we think running footwear may co-determine running biomechanics and also the associated risk of overuse injury. And 10 to 15 years ago, I think 10 to 15 years, there has been this trend of barefoot and minimalistic footwear running. And there's actually a study who showed that, or who indicated that a rapid transition from habitual to minimalistic footwear may increase stress and strain over the metatarsals. But today, minimalistic footwear seems to be not that common anymore, but rather almost every competitive athlete is using carbon fiber plate technology footwear that you see on the right. And again, there has been a discussion how a rapid transition from habitual to new footwear, in this situation, carbon fiber plate footwear, may increase stress and strain over certain parts of the lower extremity and may contribute to a different injury distribution or potentially increased risk of overuse injury. So our recommendation is, whenever changing the type of footwear, give the bone some time to adapt and maybe even periodize the training. I want to talk a little bit more on the running form, running style, as again, movement patterns have the potential to alter the magnitude, rate, and direction of bone loading. And one of the most discussed biomechanical parameters are, when it comes to bone stress injuries, loading parameters, including vertical ground reaction force. But when you take a look at the literature, there seems to be conflicting evidence if vertical ground reaction force really is associated with a higher risk of bone stress injury. And besides vertical ground reaction force, many other biomechanical parameters are discussed to increase the risk for bone stress injury. And you're a biomechanics group, so you probably better know much more than I, but these are the parameters that have been discussed in the literature, including peak rear foot eversion, hip adduction, knee flexion, hip range of motion, leg length discrepancy, foot morphology, ankle dorsiflexion, foot strike pattern, and so on. And from my clinical perspective, I just want to add to this discussion that I really think it's important to have in mind at what bone site and at what injury we are actually looking at, because I think it make a huge difference if, even when it comes to the tibia itself, we are talking about posteromedial or anterior bone stress injuries. So when talking about running form, this immediately leads me to the question if gait retraining is something we should recommend to runners with a bone stress injury. And I typically first introduce the audience to the preferred motion pathway, but I'm pretty sure I do not have to do that, because this is a model that was proposed at the University of Calgary, stating that a musculoskeletal system has the preferred pathway of a given movement. So the individual runner or athlete may choose a preferred running form. And this would make me as a clinician think that running gait retraining would not something we would typically recommend to a runner. But when it comes specifically to bone stress injuries, there's actually literature that suggests that running gait retraining may be beneficial. And one of the most commonly used running gait retraining interventions with athletes having a bone stress injury or want to prevent one is a reduction of stride length. But the problem with a reduction of stride length is that this increases the number of strides if you want to run a given amount of mileage. So there has been this nice simulation from Brent Edwards, who did some finite element analysis of runners running their preferred stride length and then a 10% reduction in their preferred stride length, and actually showed that the probability of stress fracture decreased. And this was clinically supported by a recently highly published study from Steph Klitemis et al. In the British Journal of Sports Medicine, who showed that a low step rate was an independent risk factor for bone stress injury in a prospective cohort of 54 cross-country runners. So yeah, the initial question if gait retraining is something, if this is something we should consider in athletes with a bone stress injury, I cannot finally answer that question. I just can, from what I was just presenting, say you how we clinically deal with that we do consider gait retraining, but only in a selected case, only in selected cases. All right, moving away from risk factors on bone stress injuries, I would like to talk a little bit on how to diagnose and how to treat these injuries. And when it comes to the diagnosis of bone stress injuries, I think patient history taking and clinical examination is absolutely key. And then imaging should just be used for confirmation of diagnosis, treatment decision-making, and prognosis. So we need to know that there are populations at risk, including track and field gymnasts, dancers, basketball, soccer players, and military recruits, who typically report pain with loading. They typically have no pain if unloaded. The pain typically increases with continuation of training, which is sometimes quite important to ask because due to the atraumatic etiology, there's one differential of tendinopathy. And with some types of tendinopathy, the athletes report that they need some kind of warm-up period. And after that, they can easily finish their training, which is typically not the case with at least the high-grade bone stress injuries. In the clinical examination, you can palpate the injury site, which is typically painful. Of course, this is kind of difficult when you have soft tissue, like with the femur, and you may even palpate a lump. And from the side of clinical testing, I really prefer using the single leg hopping test, which I kind of like to use as a screening test for bone stress injury. Or, of course, it's not very specific, but for the lower extremity, I think this is a quite nice test you should perform. And then there are, of course, some specific injury site tests like the spine extension test for the vertebral arc, the fulcrum test for the femur, and the calcaneal squeeze test for the calcaneus. When it comes to imaging, it's very important, and I just say it again and again, that X-rays have a low sensitivity, and many cases of bone stress injuries are not seen on X-ray. And if you see some findings, then typically after a considerable amount of healing. But some bone stress injuries are never positive on X-ray. So the gold standard is MRI, although you can see some indirect or direct findings on X-ray. So on the very left, you see a band-like sclerosis of the calcaneus, indicating a calcaneal stress fracture. In the middle, you do not see a fracture line, but a little bit of callus formation at the metatarsal shaft, indicating a metatarsal stress fractures. And on the right, this is an imaging finding called the dreaded black line of the anterior tibia, one of the most difficult to treat bone stress injuries. And this is why they are called the dreaded black line. And many of these athletes finally need, unfortunately, surgery to get this fixed. Nevertheless, MRI is the gold standard, and this is a very nice case where we have X-ray, CT, and also MRI, and this is a medial tibial head stress fracture, and you do not really see this on X-ray, you do not really see this on the CT, but when it comes to the fat-suppressed imaging, you see marked with A very clearly the bone marrow edema and marked with B the hyperintense fracture line or fracture-like defect, and corresponding hyperintense findings marked with C and D. Another imaging case is this third metatarsal stress fracture, again marked with a little bit of callus formation, but easy to oversee. But then when it comes to MRI, the bone marrow edema is present, marked with B, and correspondingly hyperintense with C, and a little bit of, what seems to be a fracture line marked with D. And what's very important to look at, and what's very helpful to diagnose this injury, is a soft tissue reaction around the bone marked with E. And I always recommend to use some kind of skin marker marked with F, because it really helps to correlate imaging and clinical findings in the athlete. There are many differentials you have to consider, including in athletes tendinopathy, also muscle injuries, tumor, osteomyelitis, rheumatic disorders, and many more. But it's also important to consider bone stress injury as being a differential, because a delay of diagnosis is very often seen, and sometimes a diagnosis or something that has been called a quad strain may be confused with a femoral shaft bone stress injury. A pubic bone stress injury may be confused with something named a groin strain. A calcaneal bone stress injury may be confused with plantar fasciopathy. Just a few weeks ago, we had a patient who was told to have low back pain and exercise, and continuing running would be very beneficial to treat this issue, but in fact it turned out that it was a sacral bone stress injury, and a fibular bone stress injury may be confused with a fibular tendinopathy. I want to talk a little bit on something we call bone marrow edema, or some people may call it bone marrow edema syndrome, as I really try to better understand what this is, and I do not have like a final answer what's the underlying etiology of bone marrow edema. And to better understand this, I think it's quite important to take a look at the history. As in 1971, MRI was invented, and by the way, there was a Nobel Prize for that. Then in the 1980s, MRI were widespreadly used, and in 1988, the first time bone marrow edema was used, but not in athletes, but rather in 10 patients with transient osteoporosis of the hip. And this is the original publication. And what you see here is that the authors said the authors believe that the findings on MRI images represent a transient increase in bone marrow water content. And they also say that for a lack of a better term and to emphasize the generic character of the condition, the authors termed this condition the transient marrow edema syndrome. And then in 2000, there was a study from Switzerland, Zurich, where they did some histopathological studies on findings of bone marrow edema in patients. And what they actually saw were some non-characteristic abnormalities that included bone marrow necrosis, bone marrow fibrosis, trabecular abnormalities, but only a small amount of edema. And this is the study from Switzerland. So today we know that the etiology of a bone marrow edema can be trauma, it can be microtrauma, it can be infective, it can be neoplastic, degenerative. And we have to state that bone marrow edema as a term is not really a diagnosis, but rather an MRI imaging feature. And of course, bone marrow edema can be of unknown etiology, and sometimes even biopsy may be necessary, but this does not mean that we have to name it a syndrome. And when talking about bone marrow edema findings or lesions, or whatever you want to call it in athletes, there's a highly clinically relevant topic on how to deal with incidental bone marrow findings on MRI. And this is a topic that's getting more and more important, because especially with the elite athletes, they get an MRI right away. So they have Achilles pain, they get an MRI right away, they come back with the MRI, and you see some bone marrow edema in the, let's say, metatarsals. So you go back to the athlete, you palpate the metatarsal. The athlete is asking you, why are you examining my midfoot? I have pain over the Achilles. So the question really is, how should we deal with incidental asymptomatic bone marrow edema in athletes? And some people may say this is just a physiological reaction to training and it does not have any clinical consequence. And some people may say, well, from everything what I just said in the last minutes, some people may think, yeah, this is just a very early sign of bony overuse, and this should be treated accordingly, or we need at least to be careful in these athletes to avoid progression to a stress fracture or to a higher grade injury. But that's evidence medicine. So almost all studies show that it actually is something that's clinically not that important in athletes. It seems to be some kind of physiological response, and it does not progress to a complete stress fracture. At least that's what the literature indicates. However, when a bone stress injury is symptomatic, or when you have a real stress fracture or high-grade injury, we need to ask the question how to treat. And when it comes to the treatment of bone stress injury, there's a really important concept to know, and that's the idea of low and high risk bone stress injury. As the treatment of a bone stress injury depends on the anatomical location and the associated probability of a treatment complication. And the good thing is that most bones, or many bone stress injuries, are located at injury sites and bones we consider to be of low risk for complications, which can be non-union, delayed union, which can be fracture displacement. But this makes it even more difficult to oversee the high-risk bone stress injuries, which can be located at the femoral neck, the anterior tibia, the medial malleolus, the metatarsal basis, and the navicular bones. So with low-risk bone stress injuries, you typically recommend an activity modification, and you may add non-weight bearing or protected weight bearing and immobilization. Although this is not mandatory, I typically recommend this if they have pain with daily activities. You may think about an underlying risk factor in assessment, including blood drops, bone density, maybe gait analysis. There are some additional treatment approaches I would like to mention that have been thought to ensure or accelerate bone healing. Although for me, it's quite important to say that right now, I don't see that there is enough evidence to recommend this on a regular basis. And as soon as the patients are pain-free with daily activities, or a few days after, you may start with gradual loading and return to sports activities. When it comes to high-risk bone stress injuries, the situation is different, because the athletes typically need to cessate the activity that led to the injury. You typically have to recommend for non or protected weight bearing and immobilization for a long time, often for 6 or more weeks. This is why with the elite athletes, you have to discuss the alternative of a surgical fixation. And if you want to go for that, there's probably best evidence for the femoral neck, navicular bone, anterior tibia, and 5th metatarsal. I typically recommend in high-risk bone stress injuries an underlying risk factor assessment. Again, you may think about additional treatment approaches. And after this time, gradual loading and return to sports is initiated. I want to show you a few clinical case examples. So this is example case number 1, a low-risk stress reaction of the 3rd metatarsal shaft. Metatarsals in general are among the most common locations for bone stress injuries. In this case, as in almost all metatarsal bone stress injuries of the shaft, we did go for non-surgical treatment. We did not even immobilize or did use protected weight bearing. And the diagnosis was made in early March of the last year. In the same month, we started a return to sports protocol, and 7 weeks later, the athlete again was running a marathon. This is example number 2. Now this is a high-risk bone stress injury located at the 5th metatarsal base, as you can see right here. And in general, 5th metatarsal base fractures, no matter if traumatic or stress fractures, are differentiated into 3 zones, zone 1, 2, and 3. The stress fractures are typically in zone 3, although they can be in zone 2 as well. And you may treat them with non-weight bearing and immobilization. However, literature suggests that you have a considerable amount of athletes non-healing. And this is why in competitive or high-level athletes, many clinicians recommend for surgical fixation of 5th metatarsal stress fractures. This is example number 3, is a low-risk bone stress injury of the posteromedial tibia. Here on the right, you see a bone marrow edema and a posteromedial localized soft tissue reaction. When it comes to the tibia, it's highly important to understand that there are posteromedial localized and anterior bone stress injuries, as we think that the posteromedial bone stress injuries are compression-sided, and bone likes to heal when it is under compression, and the anterior bone stress injuries are located tension-sided with a high risk of non-healing. And the final clinical example I would like to show is, again, a high-risk bone stress injury of the navicular bone. Patients typically report pain over the navicular spot localized between the anterior tibial tendon and the extensor hallucis longus tendon. With the navicular, and that's the reason why we consider this to be a high-risk injury, we have concerns of blood supply in the middle third, which is thought to be a relative avascular zone. However, healing is achieved in most cases if you either go for screw fixation or a long-time immobilization and non-weight bearing. But if you don't do immobilization and non-weight bearing or protected weight bearing, nor screw fixation, something like this may occur, that the patient with the initial navicular bone stress injury is coming back after 9 months, still having pain over the navicular, and still having, not really seeing a convincing bony union. So after the initial treatment phase, return to sports is initiated, and there are a lot of rehabilitation protocols in the literature, and I'm not going on to detail on this particular return to running protocol. Once you're taking care of the athlete, you may really take a look on this very specific, but most of the return to sports protocol are based on the same principle, including gradual loading of the bone, which fortunately does mean that most of the athletes can do some no or low impact activities during rehabilitation, including swimming, deep water running, cycling, elliptical training, strength training, and anti-gravity treadmill running, which I think is a good indication for bone injuries and the rehabilitation of bone injuries. Nevertheless, if you're an athletic trainer or clinician or coach who takes care of the rehabilitation process after a bone stress injury in your athlete, you really need to individualize these general return to sports protocols. And this is just an example week of one triathlete that we took care of. He just said, okay, I'm a triathlete. I need to rehabilitate from this bone stress injury. I try to increase my low impact activities and decrease the running activities. So on Monday, he did some swimming and biking. On Tuesday, he was on the anti-gravity treadmill and some biking. Wednesday, biking and swimming. Thursday, he did a little bit of running and biking. Friday, biking. Saturday off. And Sunday, outside running. And then in the afternoon, deep water running, which I really like as an rehabilitation intervention or approach in athletes with a bone stress injury. The athletes always want to know, how long does it take me off, when I can come back? And it really turned out, as indicated by this BGSM study that we recently published, this really depends on the location of injury, as again, there are low-risk bone stress injury where you can really be progressive with return to sport, just as the posterior medial tibia, where the athlete may be back after 7 weeks or 8 weeks, and almost all athletes return to sport after posterior medial tibial bone stress injury, with high return to sports rates are typically seen. But then when it comes to high-risk bone stress injuries, like the navicular, which can be very frustrating to treat as, yeah, for both the athlete and the clinician taking care, these athletes typically do not return earlier than 4, 5, 6 months back to sport. And you also have a considerable amount of athletes who are not returning to sport after navicular bone stress injury. And this is why it's important to talk a little bit on screening of bone stress injuries, as the early identification of bone stress injury may be important to reduce the risk of progression to a complete bone fracture and to expedited return to activity. But the problem with screening for bone stress injuries is that the direct measurement of micro damage, stress, and strain in vivo is invasive and therefore not routinely feasible, although you can do, as this nice study from David Burr and his colleagues did. They used this strain measuring staples implemented in the bone, and this is how this may look on the X-ray. And then they were able to measure walking and running, bone strains during walking and running. But again, not really practical in a clinical setting. So we have to think about alternative approaches to screen for bone stress injuries. And one approach is finite element analysis, which is a method for virtually analyzing stress and strain and the behavior of bone under loads. Although, at least to my knowledge, this is more a research tool right now rather than to be used in a clinical setting. So when it comes to clinically screening bone stress injuries, it all comes to accurate monitoring of training load and risk factors. And this is why, at least with the German national team, we use an online platform where the athlete can put in all the information, and this may give the coach or the medical staff an idea of the athlete who is at a state of overuse. But the problem is, with the more training load data you get and the more risk factor you assess, the question is, what are the actual parameters or what are the connections between the parameters that really predict a state of overuse before actually developing a bone stress injury or any other type of overuse injury. And this is why we are currently running a large prospective study where we try to assess as many training load parameters and risk factor parameters as possible, and then using a machine learning approach with the idea that the machine is telling us if there are any connections or parameters that may be used as a predictor of a state of overuse before actually developing a serious injury. And this is what already brings me to the conclusion and the end of this topic and talk on bone stress injury. Bone stress injuries can be devastating in the athletic population. However, with early diagnosis and adequate treatment, there's a good chance of recovery without permanent damage to health. Bone stress injuries comprise a spectrum of entities, so they can be low grade, they can be high grade, they can be low risk, they can be high risk. And it's quite important in specific to identify the high risk, high grade bone stress injuries, as these injuries should be treated with special care. You should always listen for patterns that make sense. So when you have a basketball player with fifth metatarsal base pain, there are not that many differentials. So think of this being a metatarsal stress fracture until proven otherwise, as you should rule out the worst injury before assuming a simpler one. Overall, the treatment spectrum is broad, so some injuries do not need to be immobilized, others need surgery, and both under and over treatment should be avoided in athletes. If in doubt, order rest, non-weight bearing, and refer or talk to somebody who is seeing these injury on a regular basis. Freedom from pain is actually a good clinical indicator for bony healing, which also means that training load must be reduced when new symptoms occur. And I think I made that clear, that the identification of underlying risk factors, such as relative energy deficiency in sports, is important to support healing and to prevent re-injury. If you're as interested as I am, feel free to read our review that was published last year on bone stress injury. And I really hope we can have a nice discussion on these injuries. And I would like to thank you for your attention.
Great presentation, Ken. You mentioned that retraining should be only done in selected cases. Would you be able to give an example of this type of selected case?
So I do not have evidence that I can stay here and say this should be done only in selected cases. This is just the approach, how we deal with this issue. And the typical gait retraining parameter that may be applied is a stride length reduction. And then it may come just to a very individual approach if there are some really non-normal gait parameters, although that's very interesting topic to discuss, what's a normal gait parameter. But if we then from a clinical standpoint say, okay, this is so much out of the norm, maybe this may be an intervention that we should do, as sometimes it's really, really hard to take care of athletes with bone stress injuries. Sometimes it's really easy with, as I just showed, some have a high rate of return to sport. You have this treatment approach, return to sports protocol, and then everything is fine. But then you sometimes have athletes who have a non-union, or even some athletes who come to you with the third or fourth bone stress injury in the row, where you, as a clinician, you really feel like you have done everything that you should be done, including risk factor assessment, but still you're not really have the feeling that you're good in taking care of the athletes. And these are the situations, again, as I said, in like selected cases where this is something we may consider, although it's always, of course, very difficult, like in competitive athletes, to tell them they should change their way of running. No doubt about that.
So you mentioned that it's not about just the load that you're training, but that it's more like this transition periods. Is there something in particular that's a feature that you look for in that transition, or is it just like say like the rate of increase, or is it within the first so many months of a new activity until the bone is able to adapt and that kind of thing?
Yeah, that's a great question. And the reason is that we do know that there are several parameters that may increase the load to a bone. We should not only look at the training volume, but we should also take into consideration training intensity, how fast they're actually doing their runs or the training activities, how intense are they training. But of course, the most easiest is just to look at the mileage. So this would be clinically the first thing we would take a look at the last 6 to 8 weeks. Was there an unusual increase in mileage? But of course, this is an interesting discussion going on clinically and scientifically. What's the best way of really measuring loading that is beyond just taking a look at running mileage or the total amount of training the athlete is doing?
Well, I just want to follow up on that question, because I saw you reference the Tim Gavitt when you were talking about the German the program that you used in Germany. So, and you said something just now about running mileage. So are you using the acute chronic workload ratio at all? And I know this is a big debate. I'm not looking to get into an argument.
So I feel like it's hard for me. I know there's this discussion going on with some being pro and some being contra. I really think that the general idea that we have to look at recent changes, something that recently changed to what the athlete is used to do, I think that's really important to do. When it comes particular to this acute chronic workload idea, I feel like I don't want to be in the position where I say I'm absolutely pro, I'm absolutely against it. But I think it's important to take a look at what the athlete is used to do and what he recently did, and if there were some recent changes or something unnormal or unusual.
So in the example for the triathlete, the return to sport training program, you have both the Ultra G or like the anti-gravity treadmill and water running. They both offload the bone, but they have different physiological like intensities. So how do you choose what to use when, which to use?
So we like to use both, and for us, it's not that we first start with the one approach and then go to the next. Especially in a rehabilitation setting, it may be not nice for the athlete to have some different approaches, so that they are not, especially with the elite athletes who are used to train once or twice a week and every day, they are not just on the bike. So we try to use both. And yeah, the idea is of gradual loading. So when the athlete is pain-free, we try to get as soon as possible to 80% of body weight on the anti-gravity treadmill to really increase this physiological training response. And yeah, but we also use the water running. Yeah.
You mentioned gait retraining. Could you give me an example where you did that, why you did that, what you did, and what the outcome was?
Yeah. So as I said, these are very selected cases. But when it comes to an athlete who's coming to us with a fourth, fifth bone stress injury in a row, like in the last 5 years, and you feel like you have done all the risk factor assessment, underlying bone biology, and you feel like you've done everything that you could done, then yeah, we may refer these athletes to our physiotherapist that do a gait retraining. And yeah, I mean, the first intervention probably,
What do you tell them to do?
the first intervention would probably a reduction in stride lengths. Why? That's the literature suggesting. So it's mainly this, yeah, the idea is brought up here in Calgary, and then this Clitemis study, who's really, yeah, suggesting that this may be beneficial for athletes suffering from a bone stress injury. But again, do I really?
In a jump from reducing stride length to bone stress reduction. What happens? What can you explain what happens, or is it just
I mean,
statistically something that happened?
Yeah, it's just the idea to try to reduce the loading in a training session. That's the idea. Do I really have evidence this is something we should do? No. Do I have evidence that this is really beneficial? Like we had like 10, 20, 30 athletes and they never had a stress fracture again? No. But it's one treatment approach we may think about.
There's a lot of great literature on this topic.
What's your opinion? I would love to.
I wouldn't know it. Now you are in the clinic. if you could wish to have some kind of instrument or measuring device that would help you in your diagnosis, let's say for stress fracture, what would it be?
MRI.
But you can buy that.
Yeah.
So the MRI would give you the best help.
Yeah.
It would not be a biomechanical measurement system that calculates some.
So for the diagnosis, I think MRI is the best tool or thing we should have in clinic.
So if Brent would work in your group, what would you tell him to do? Try an MRI or what would you?
I would probably tell him that we need to better understand how the biomechanics are related to bone stress injury. So what I would love to have, but unfortunately I do not have it, the biomechanics in the best case prospectively collected of, let's say, 200 patients with an metatarsal 3 shaft bone stress injury. And that's compared to a control group. And I think if I would have Brent Atwoods working with me, like the biomechanical expert, this would something I would clinically be really interested to get this real world data on the underlying biomechanics of athletes developing a bone stress injury at a very specific site. So I do not think it does make sense to take a look on all bone stress injuries of the foot. I do not think it does make sense to compare biomechanics when it comes to navicular and metatarsals and tibia. I think this is something where research may go in the next years, that we take a closer look on the individual bone specific area of injury and the individual stress and strain at a very specific side of the human body, rather than just, have some kind of, even with wearables, like overall measurement of bone loading placed at the lower back or the tibia, and then correlate or try to have an association to some very, let's say, navicular bone and comparing this to metatarsals.
So kind of talking about the MRI, so you said that there's low sensitivity of X-ray for detecting stress fractures in like the outside world, outside of like a research hospital kind of setting. How often would an athlete or an individual with like signs of a stress fracture be actually receiving?
I think this really depends on the healthcare system. So in Switzerland, Germany, it's probably close to 100%, but I know there are other regions in the area, in the world, where you do not really have access to MRI. And this is a very nice discussion going on clinically if you actually have to do it, because, if we take care of elite athletes, it's not really a big deal to get all these things done in a short amount of time. But let's say just somebody who has a busy outpatient clinic, seeing a lot of patients within a few minutes, is it really necessary that everybody with where we think a bone stress injury may be present should get an MRI? And I mean, typically with our workflow, it is that everybody should get this MRI when we have the idea of a bone stress injury. But I feel totally okay if somebody is saying, okay, I do an X-ray to rule out some severe injury, and then I diagnose this clinically with low risk bone stress injury, because would this really change treatment in, let's say, a recreational runner who has a metatarsal bone stress injury of the shaft? Would an MRI really make us do a different treatment decision making? Probably no. So I feel like it's not necessary that everybody needs to get an MRI. And I mean, you can talk to the athlete, you can examine them, maybe you can use some point of care ultrasound, X-ray, and I mean, but that's a question if everybody should get an MRI. And probably the answer is not everybody really needs to get one. With the high-risk bone stress injuries, I would recommend. So if you think there may be a navicular injury, I would recommend to do that, yeah, if you have access.
It's a perfect transition from running to imaging, so thank you. So I appreciated our discussion about bone marrow edema the other day, and one of the things that I find surprising is that the study you cite looking at the underlying histopathology on bone marrow edema is from the OA population. So, which I'm curious your opinion as to whether that has any bearing on what happens in an acute injury situation in an athlete, whether the underlying tissue changes that produce that image on an MR are going to be similar in OA as a athlete.
Yeah, we had this discussion yesterday or 2 days ago. It's great, and I do think we need some new histopathological study. I mean, this is from 2000, where we really have to take a look at different populations, including because we see bone marrow edema in patients, let's say, with osteoarthritis, and we see them with underlying micro damage in the athletic population. And yeah, that would actually be nice to study to histopathologically, then take a look at what is both hyper intense in the imaging, if there's a different underlying etiology on the histopathological level. And the next question then, of course, would be, are there any opportunities for sequencing to differentiate bone marrow edema due to, you know, degenerative or macro trauma? But yeah, I feel like we need to better understand what the underlying histopathological issue of a bone marrow edema is. That's my feeling, that this should come first before thinking about new imaging sequences. And yeah.
And in the bone stress injury situation, like I've seen lots of MRs from ACL injury, we talked about that, like, which is a very diffuse pattern of bone marrow edema or whatever you want to call that. In the bone stress injury, is it similarly quite diffuse, or is it really contained to the site of the injury, like more like in a knee osteoarthritis?
It can actually be quite large. So the pain may be localized, very distinct, let's say at the metatarsal shaft, but the bone marrow edema may be all around the metatarsals. And what's also not uncommon to see is that even bones that are close to the injury region also have an hyper intense finding. So yeah.
Why do we call it bone marrow edema?
I don't
when
know.
It's around the periosteal.
I don't know.
Okay. I had a question about recurrent stress fracture. I'm wondering if somebody comes in and they present with 4, 5, 6 stress fracture. Have you ever had a patient that had normal blood levels, normal bone mineral density, no red S, like all these other things that I would think are huge risk factors for multiple stress fractures? Have you ever seen a patient like that? So none of that stuff, but they have a lot of stress fractures.
Yeah, sometimes you have the situation where you feel like everything is perfect and you don't really understand why this athlete is developing a bone stress injury. And then it basically comes to training load, when you feel like you have anything ruled out. But the reality is that when you do bone mineral density measurements and vitamin D, at least with the population we are dealing in Germany, where more than 90% is thought to be having a vitamin D deficiency, then you have some findings you may consider to be pathological. The question always is this contributing to a bone stress injury, or is it just because it's the situation of the athletic population or the general population they are living in? But typically, of course, you have underlying risk factors, but then it always comes to what is pathological, what is normal. So you just talked about relative energy deficiency syndrome. That's an important question in sports medicine. what body weight is normal with runners, but because when you take a look at runners, I mean, they all have a low body weight, but yeah, when do it comes to this situation where we can really call this like a pathological finding? What's the situation when we can name this relative energy deficiency situation? So this is not always easy in the athletic population to say what findings are normal and what are unnormal. And I remember the discussion we had a few days ago on reference values with DEXA, if this should be different in the athletic population compared to other populations. So typically you have something, and I think it's good that you have something, because you can then try to address it, especially in these athletes with recurrent bone stress injuries, which does not mean that you're always successful.
Other recurring stress injuries tend to be localized around the same areas.
Yeah, you can have this. So for instance, with the fifth metatarsal, it's quite common to see that at the same bone set, but from my personal feeling, I would need to look at the literature. They are typically localized somewhere else, but yeah.
Yeah, talking about bone lesions, you know, we work with Sprague Dawley rats, and they seem to have these bone edemas, these lesions naturally, in the males at least. And we do this with a regular diet and with a high-fat sucrose diet. And just a few days ago, we realized there doesn't seem to be a difference in these lesions depending on the diet which we wanted to investigate. But then we also had two groups that had a regular diet or a high-fat sucrose diet, and we aerobically trained them or did a resistance training. And preliminary results seem to suggest that this loading actually seemed to prevent these lesions that we naturally see. So I guess the question being, could loading potentially be good for these edemic lesions? And is there potentially a genetic factor there that might actually bring out these bone lesions, let's say in this particular animal, potentially also in some people?
Can I ask a question before you answer? Because I've CT'd some of your rats before, and what I saw was something that looked like erosive damage, like more like an RA kind of phenotype. So is that the kind of lesion you're talking about, or is it within the bone marrow itself? Like
No,
in the
that's
center of the
what
bone?
I'm talking
So
about.
it's a more of almost an erosive pattern at the cortical surface rather than in the center of the bone marrow, like in the trabecular bone region. At least that's what I had seen on those rats before.
And then sometimes they collapse.
Yeah.
Yeah, so probably that comes back to the earlier question, what is the underlying etiology of a bone marrow edema? And we see clinically bone marrow edema in so many situations rather than repeated loading, including rheumatic disorders. Yeah, but I feel like this is very interesting to further read and to hear on that. But I feel like I right now have to think a little bit about this question to answer that, if loading is maybe preventive to heal
When
that.
we talk about stress fracture in this group, we always look at people that have stress fractures. And I'm always interested in the marathon runners that are world class and run 200 kilometers per week for a decade, and they never seem to get injured. Why do some people that run 200 kilometers per week year after year never seem to have a major injury?
Probably genetic factors have a role. They are discussed in the literature as risk factors for bone stress injury or impaired underlying skeletal health issues.
They have better bones?
Yeah, that may be one reason that could explain this. But in the end, we think about these injuries as being multifactorially caused. And of course, when it comes to elite athletes, it's not only the genetics that make them better, but maybe just smart training. And this is why we then need to consider all of these factors that are leading to the situation that some athletes get injured and others do not.
Just seems in some examples that, you know, people that I had considered not to be the best talented, but they never got injured. And then at the end of the day, they win an Olympic medal because they just never get injured independent of what they do, whereas everybody else seems to get injured. I always thought about that. It was interesting. But a different question, you know, we just talked about bone. When you look at stress fracture and bone quality, and so do people also look at muscle quality and other musculoskeletal tissues and how they might potentially work together, and whether or not they might indicate whether or not you're at risk for a stress fracture? Or
yeah, in fact, there's actually going a huge discussion if muscle strengths may be either protective, as they potentially offload the bone, or are they the causing factors by pulling the bone? And one of the reasons I did not mention really, or I slightly mentioned it when with the risk factor slide, but I did not go into detail because I do not have a final answer to that. Although it is clinically very important, because when you have somebody who is in the rehabilitation process after a bone stress injury, it's kind of important if we implement muscle training or if we don't. So or strength training. So yeah, the discussion that's going on in the literature is both that it either can be preventive, but also causing stress or contributing to bone stress and strain.
just a couple of clinical questions. That when you do your one-leg hopping test, which you said was your favorite test, what do you look for?
Pain.
Pain.
So it's basically a loading test, and yeah, if the athlete has pain, that's for us as a diagnostic test that makes me to think, okay, we may have an underlying bone stress injury. We may.
The other thing that you showed that I was really curious about is this black line tibia fracture thing. And you said, you know, in a high performance athlete, I need to go in surgically because otherwise it's not healing or too long. So what do you actually do surgically?
I had a great discussion yesterday with Professor Mutadi, who did surgeries for like 30 years, and he told me how surgical techniques changed with anterior tibial stress fractures. So the literature is suggesting that the best surgical procedure is anterior tibial nailing.
So to cause compression, or
yeah,
to
cause compression, or the idea is to offload the injury site and to create loading on the tibial nail rather than the cortical bone. But that was one question I was discussing yesterday with your colleague, and we do not really understand why these particular anterior tibial stress fractures are so prone to not healing, and why many surgical approach do fail. With anterior tibial nailing among the surgical approaches that we have, although in my feeling it feels like kind of very invasive for a young athlete to do an anterior tibial nailing, seems to be the approach with the best surgical outcome.
Can you explain to a non-surgeon what that actually, how that looks like when you say anterior tibial nailing?
Yeah, so you go here, I mean, the bone, of course, there's a cortex, and then there's the trabecular region, and then you just put a nail from above through all the tibia, and then you fix it with screws. So it's a big, exactly.
It's an intramedullary kind of rod.
Yeah, exactly. And that's
why don't you just take a little?
Yeah, exactly.
If I was a surgeon, I would take a flat plate. I would screw in two things.
Yeah, that's a surgical technique that there a lot of techniques have been used for treating anterior tibial stress fractures. point with a plate is that you have to take it out. It's directly under the skin. That's not very comfortable for the athletic population. And the most important thing is to ensure bony healing. And with many surgical techniques that were described, it does not make any sense to use a surgical technique when it fails and you don't reach your goal. But again, there is not that much evidence on different surgical techniques when it comes to anterior tibial stress fractures, which are fortunately which have a lot lower incidence than, let's say, posterior medial bone stress injuries. But that's when you take a look at the literature, that's the most recommended surgical technique, tibial nailing. Yeah.
So do you see stress fractures in children?
Yeah.
Teenagers?
Yeah, we do them. Yeah.
I was just wondering if maybe not so much the bone quality, but maybe the ability to repair quickly might protect you from stress fractures. Has anybody ever looked at what the capabilities of different bones are and how they generate and how quickly they can repair, and like the natural?
My guess would be that it's a lot better in the younger population, but in the end, it feels like that you can break every bone if you just put enough stress and strain. So then it really comes to, even if they are capable of managing all this load, when you overtrain them, then you may still in a population who are from a skeletal situation not at risk or at high risk of developing a bone stress injury. If you overload them, then you may even make these bones to break or to see some to damage. Yeah.
We'll end it. Okay, it's 4:20 now. So we have a thanker speaker again.